in liver transplant, and he will be talking to us today on the role of PLEX in acute liver failure mimics.
Thank you. Good afternoon, all. Um, Thank you to the Department of Medicine for this invite. And over the next 15 minutes or so, I hope to briefly touch on the role of plasma exchange in acute liver failure mimics. Just to give you an overview, we'll quickly look at definition and arriving at a syndromic diagnosis of acute liver injury and acute liver failure. What exactly do you mean by ALF mimics, and how common is hepatic dysfunction in these scenarios? What is the role of PLEX in ALF, and can this evidence be extrapolated to ALF mimics? So we have a 16-year-old male who presented with history of high-grade fever, myalgia, and lethargy for 5 days. Now, by the time they sought medical attention, he was noted to have some yellowing of eyes, and by then the fever had settled. No altered behavior and no other significant past medical history. Examination, he appears dehydrated, he is icteric, and on examination, he just has a palpable liver. I've given you the labs here. So hemoglobin seems to be 16.3. Total counts are slightly on the lower side. Platelets are 35,000 and has an abnormal LFT, high bilirubin. Enzymes are more than 10 times upper limit of normal and an INR of 2.8. His viral markers were negative on testing. So I just want you to take a few seconds to think what syndromic diagnosis you would give him and what etiology you would like to test for. Okay, for want of time, I'll keep moving. And so the answer to the previous question was acute liver injury. And acute liver injury is, or severe ALI as it is called, is hepatic dysfunction, which is jaundice, with coagulopathy, which is defined as an INR of more than 1.5. And ALF is severe ALI with onset of hepatic encephalopathy. So hepatic encephalopathy is an absolute prerequisite for making a diagnosis of acute liver failure. It's not just a really bad looking LFT. The prerequisite for making a diagnosis of ALI and ALF is that the baseline liver function should have been normal. Now, coming to the topic in hand, which is ALF mimics. What do you mean by ALF mimics? So patients with tropical infections such as malaria, dengue, typhoid, leptospirosis, and scrub typhus can present with jaundice, encephalopathy, and can mimic ALF. I'll come to why I'm saying mimic ALF in a minute. Now, a proportion of these patients with complicated illnesses die, especially of multi-organ dysfunction. So before we go into why I'm calling it ALF mimics, it's important to understand this concept of hepatotropism. So the distinction between hepatotropic and non-hepatotropic viral infections lies in their primary target organ or tropism. So these organisms specifically target the liver as their primary site of replication and then infect, damage the liver, and go on to cause the disease. Now, so these are two graphs here. On the left, we have a graph from the West, which are common causes of ALF. And you can see that what is given in green is predominantly drug. And the large part of this is due to paracetamol. And on the left, we have causes of ALF from India and the Indian subcontinent. And you can see that a large part of it is predominantly viral. The reason I put this slide here is to just tell you that ALF mimics do not figure in the statistics of these causes of ALF. So they are just put as tropical infections or ALF mimics and are not typically represented in ALF statistics. Now, going on to this question, so why is it relevant to talk about it? And do we have enough information to say that liver dysfunction is seen in these infections? So from now on, I will use dengue as a prototype and talk generally on dengue and dengue-related liver dysfunction. So I have a few studies listed down here. And if you see this column, you see that about 80 to 90% of these patients across different studies, and you can see that many of these studies are included more than 1,000 patients, have a high AST. ALT was seen elevated in about more than 40 to 80%. Typically, AST was higher than ALT. Some of them did have hyperbilirubinemia, somewhere from, say, 10 to 40%. And a few of them, somewhere around 10%, had more than 10 times the upper limit of normal elevation of AST and ALT. So is it there? Definitely. It is common in these infections. This is a recently published study from Surat, where 1,600 odd patients were looked at with dengue fever. 12% had dengue hepatitis, and despite supportive care, none of these patients had PLEX. 17% of dengue hepatitis patients died. Mortality in dengue hepatitis patients who progressed to ALF was almost 40%. The second is a study from St. John's, Bangalore, where incidence of ALF in patients with dengue infection was noted to be 36 out of a denominator of 10,000 patients. And all of these patients, of the 36 patients who progressed to ALF, 58% died. So we are talking about a high mortality illness here, right? Once we reach a diagnosis of acute liver failure, the first question is to see if they fulfill listing criteria for liver transplantation, and then to start having talk about that, etc. Now, this is a difficult decision, and for multiple reasons, especially in the role of liver transplantation in tropical infections such as dengue, malaria, etc., is not very well characterized. It has been done, but clear guidelines do not exist. Say somebody has acute dengue infection and has a platelet count of 30,000 and has ALF. Is the surgeon happy to take him up for transplant? Probably not. So the guidelines here are not very clear. That is one. Second is, are we too early in recommending transplant? Is this an illness which is likely to have spontaneous recovery? If we are too late, that is, the patient becomes too sick to undergo a transplant. So a multidisciplinary approach becomes very important, and this will always remain a difficult decision for any patient. Briefly, to tell you how difficult it is for a patient in India to access urgent liver transplantation, this is the reality only for a minority at present. So about 1,000 liver transplants happen in the country, predominantly live donor transplants, and about 5 to 7% of these transplants happen for acute liver failure. The remaining, more than 90%, happen for chronic indications such as decompensated cirrhosis or acute on chronic liver failure, etc. Now, the second line is actually an estimate of how many patients develop significant liver dysfunction and acute liver failure due to rodenticide in Tamil Nadu alone over a 1-year period. It's an estimate, it's not an actual statistic, but that is about 500 patients. So you see how big the mismatch between availability and the access to transplant is. So then what is the need? So you need a non-transplant treatment option in a resource-constrained setting, not just as a bridge to transplant, but as a standalone treatment. And here is where plasma exchange figures in. So now over the next 1 minute, I'll try and talk to you about how PLEX may work in acute liver failure. VWF has been studied as a candidate molecule, macromolecule in liver failure syndromes, and has been studied as a prognostic marker in liver failure syndromes in both acute and acute on chronic liver failure. These are 3 studies from our center, so the normal VWF value in a patient with normal liver function is 50 to 150%. And here we can see that across all 3 studies, it was about 4 to 5 times elevated or even more. As the VWF increased, there was increasing severity of the illness that was noted as well. Acute liver failure is a syndrome characterized by overactivity of the innate immune system. This is typically tested, or how do we prove this? This is seen as elevated VWF, elevated ferritin, and elevated CD163 levels. Now, this is again another study from our center. This is in rodenticidal hepatotoxicity and not in dengue. But as the MEL score went up, we can see that ferritin went up, CD163 went up, CD25 went up, and and VWF went up. So there is good correlation between markers of innate immune activation and increasing severity of liver dysfunction. So we know that there is RE activation and endothelial activation. Low-dose steroids are used to ameliorate the RE activation, and removal of VWF by plasma exchange reduces or ameliorates the endothelial activation. So these are the therapeutic strategies that have been used to improve liver failure syndromes. And here we are talking about acute liver failure. High volume plasma exchange. This is a seminal study which came in 2016 by Larson, which was one of the first big trials to randomized control trials to show that high volume plasma exchange improves survival in acute liver failure as compared to standard medical therapy. Now, in our own center, these are observational studies, and across the second and third are from CMC, and the first one is from Amrita Kochi. There were 22 patients, and 14 patients underwent transplant, 8 were managed with standard medical therapy. If these patients met the listing criteria, all of them died. We managed these patients with low volume plasma exchange, 8 patients in the first study, so 75% survival, and 32 in the second study, and we had about 68.7%. So what was previously 0 has improved. It's not 100%, but it is definitely improved. We'll quickly touch on some evidence of plasma exchange in dengue. This table shows studies from different places where the first 2 allude to standard medical therapy. Mind you, these are all small numbers, I agree, but this is all the evidence that we have. So with standard medical therapy across the 2 studies, we had 58% and 38% in hospital death. Whereas in the second 2, where CRRT and plasma exchange was combined, in dengue ALF, the in-hospital mortality was somewhere between 25 and 40%. So the second study, which had 12 children, and patients, children with dengue-associated ALF were treated with PLEX and CRRT. Disease severity scores and liver functions improved in 9 children, and all of them survived. We have our own series of few patients, and we have put out 3 of these patients with dengue, hepatitis, and MODS, 2 of whom who survived. All of them were noted to have high RE activation markers, and 2 of them survived. 1 was discharged in a moribund state. So this, sorry for the busy slide, but I would just like to draw. So the first and the second patient survived, whereas the third patient did not. All of them were diagnosed with dengue. And I would just like to show probably point your attention to this line on ferritin, where this patient had a ferritin of more than 1 lakh, and by the third day of PLEX, actually day 7, after 3 sessions of PLEX, it was somewhere down to less than 20,000. So similarly, all parameters did improve in first and second patient, whereas the third patient did not do so well. One center in Vietnam also looked at their change in management protocol between 2 time periods, where initially it was only CRRT, and from 2018 onwards, PLEX was combined with CRRT to treat dengue, ALF, and shock syndrome, and they found that their in-hospital mortality improved from 87% to 37%. Again, I do agree that the denominators are rather low. Now, this brings us to the question, what is an ideal window for PLEX? When are we not too early to PLEX? When are we not too late in the game? So we do have a stage 1. If we are to stage the illness as 1, 2, 3, and 4, we have a stage 1 where you have an initial prodrome. The patient comes with fever, probably low platelets start to kick in. And then you have the second stage where you start seeing the liver injury. Third stage would be, if they do develop ALF, that would be the third stage where they develop HE, and then they can go on to develop MODS. The indications given here are what we typically use for initiating PLEX in rodenticidal ingestion related ALI and ALF. So if there is severe ALI and we are using an INR cutoff of more than 4, we start PLEX. If there is progressive injury, that is LFT is worsening and INR is worsening, despite supportive care, we start PLEX. And if there is HE at any point of time, we start PLEX. So it would be 2 and 3 would be a good time to start PLEX. 1 may be too early, and 4 is, as it's intuitive, it's too late. Now, we have started PLEX. When do we stop PLEX? Again, we do not know the right answer, but extrapolating our data from rodenticide ingestion, patients who survived and who did not, and who were managed with PLEX were looked at, and we saw that patients who had a decline in MELD by day 3, between day 1 and day 3 of PLEX, that is what stood out significantly different between the alive and the survivors and the patients who did not survive. And delta decline in MELD had a significant area under the curve. And when the cutoff of 20% decline in MELD was used between day 1 and day 3, sensitivity and specificity was more than 95% for both. So I'm coming to my concluding slides. So what all should we do when we're managing a patient with ALF mimics? I know I have talked only about dengue for want of time, but the same thing may be extrapolated to other infections as well. So identify ALF early on, initiate supportive measures. Serial monitoring of liver parameters have to be done. It cannot be on day 1 and day 7. We have to know how the liver functions are sort of behaving. If they are improving, it is, it's best to continue the current course of management. If it's worsening, see if there is evidence of innate immune activation and keep doing it serially so that we have some trend to go by. If there is evidence of innate immune activation, then consider PLEX plus low-dose steroids. When do we stop? Delta decline in MELD at some number. We do not know what the right number is, but maybe 20% may be an okay ballpark figure to start by. What contraindications should we look for? If there is significant hemodynamic instability or active untreated sepsis, then that is something that needs to be managed before we initiate PLEX. Recognition, prompt initiation of supportive care, consider early PLEX. So that is that picture on stage 2 and 3, not too early, not too late. And close monitoring with dynamic parameters. We need serial values. It's not one value and it's not the value just before the patient crashes. And we obviously need a multidisciplinary approach. So what future directions do we need to look at? So I think that there is a significant gap in knowledge on the incidence of ALF in these mimics. Nobody knows what the natural history of ALF in these patients is. Nobody knows what the predictors of response to supportive care is. What areas do we need to focus on? Look at our own patient profile and see and identify patients who progress despite best supportive care. Now, looking at that will then sort of inform us on what an ideal window for PLEX for these patients is. Thank you.